Hello. Sir, you can begin. Can you hear me on Zoom? Yeah, so you can start the meeting then. I'll disconnect from the cell phone. Hello. So you'll have to unmute yourself.
Vikram has also joined in.
Yes, we'll have to just. So which of these is? I have taken. There are two people who have joined with your name. We'll have to see who is.
Vikram hoga.
Out of the two Dr. Rakeshes who have joined the panel, if you can please start your video and audio and let us know who of you is Dr. Vikram, then we can rename you accordingly, please.
Yeah.
Else you will have to continue the meeting with the same name. Please start the video. I request you all to please start the video.
I'll just tell him on phone. विक्रम तुम अपना वीडियो ऑन कर दो तुम। अच्छा अच्छा यू कैन हियर मी ना, तो अपना हैंड रेस उसमें नहीं आ रहा है क्योंकि आई एम सीइंग टू राकेश शेयर ऑन द पैनल ऑन द स्क्रीन ओनली। वेट, फिर से एक बार लॉगिन करो तो उसको बंद करके शायद हो जाएगा। मानसी हेलो मेघा। मेघा यू देयर? हाँ विक्रम। या विक्रम। हाँ आया क्या? अच्छा यू आर यूजिंग द सेम लिंक ना, तो यू आर स्टिल ऑन द स्टूडेंट दिस थिंग ना। उसके वहां पे कॉफी रखता है क्या अभी? हाँ है तो पूछ ले, तो होगा तो ले आते। अबे के लिंक से ज्वाइन कर रहे हो? या हो गया हाँ यू आर देयर।
Start video.
Yeah.
How do I change the name?
Option.
Mansi? Yeah. Vikram, I'll just you can share your screen.
Yes,
Vikram.
I can see the screen, sir. Trying to start screen.
You can see, na? So I'll just introduce you.
Yes, sir.
Share the floor. Yeah. So good evening, everyone. Welcome you all. And today we have another round of clinical examination on the bedside. And today the topic is bedside assessment of parietal lobe function, and this will be done by Dr. Vikram Aglave. He is assistant professor in Department of Neurology at Grand Medical College, Mumbai, and he's a very bright student and just recently passed out. And he will take you through the testing of parietal lobe functions, bedside examination. So welcome,
Thank you,
Vikram.
sir. So, good evening, everyone. Today, the topic is bedside testing of parietal lobe function. So, just start. You can hear me, right?
Yeah, it's very clear.
So, we'll be discussing in brief about the left and right parietal functions and about the bedside testing and also about the clock drawing test. So, we will not discuss the sensory disturbances, cortical sensory disturbances, because it has been covered in the previous topic, previous lecture. So, we'll just discuss on what is dominant on the left side and what functions are dominant on the right side. Right? So, first we'll look at the parietal lobe anatomy. So, I just So this is the lateral hemisphere, lateral surface of the cerebral hemisphere, and you can see the sylvian fissure. This is the sylvian fissure. This separates the frontal and the parietal lobe from the temporal lobe, right? And this is the central sulcus. So in front of the central sulcus is the frontal lobe, and behind it is the parietal lobe. So in the parietal lobe, there is the postcentral sulcus, this one, which separates the primary somatosensory cortex from the posterior parietal lobe. And this posterior parietal lobe is divided into superior and inferior lobules by the intraparietal sulcus, right? So, and then the inferior parietal lobule again is divided into the supramarginal gyrus and the angular gyrus. On the medial surface in the sagittal section, you can see the central sulcus is coming up here, and behind that is the posterior paracentral lobule, and this is the marginal sulcus which separates it from the precuneus. So these are the parts of the parietal lobe. So the posterior parietal lobe is predominantly involved in the multimodal and somesthetic association centers, right? So visual spatial functions, language, and all, and primary cortical sensations, they are dealt with the by the primary somatosensory cortex over here. So what are the left parietal lobe functions? The main function is praxis, that is the execution of learned skilled movements, then visual language, that is reading, and the comprehension after reading, then calculations and arithmetic, and language related spatial functions. So spatial functions is actually a function of the right parietal lobe, but language related spatial functions like left and right orientation, this is a function of the left parietal lobe. So the lesions here produce apraxia, that is classically limb apraxia. Then they produce alexia, and they may produce the Gerstmann syndrome and its components. So we'll discuss one by one. So what is apraxia? Apraxia is the inability to correctly perform learned skilled movements. So when it is basically a specific cognitive deficit included under the perceptual motor domain of the DSM-5 criteria for dementia. So it is a specific cognitive deficit of motor programming. It's not a motor deficit, it is a programming deficit. And so there will be errors in the motor act, but not because of a motor deficit, right? So what will be the errors? Either there will be a spatial or temporal processing error. That is the way, suppose we have a skilled movement like shaving or brushing the teeth. That is a skilled movement that we learn as we age, right? And the errors because of this deficient motor programming will produce spatial temporal, like the trajectory of the hand, the way the hand holds the toothbrush or the comb. These are the motor execution errors. And content of the action, is like if you are brushing, you are asked to patient to brush the teeth, the instead he will not know the use of a brush, right? So the content of the action is gone, so he will not be able to perform it, right? So and the definition includes, it should not be due to a motor or sensory deficit, it should not be because of an involuntary movement or posture, and it should not be because of any other cognitive deficit like memory, attention, language. So all of these have to be excluded to call it as apraxia. Now apraxia usually co-occurs with all of these cognitive deficits in many conditions, but you can only diagnose apraxia if these other conditions recover in these cases, right? So lot of conditions have been misnamed as apraxia, but there are only really three or four axes which are really a disorder of learned skilled movement. One of them is limb apraxia, which is determined by the left parietal lobe. The other, the orobuccal pharyngeal apraxia, like whistling, blowing, or apraxia of speech. These are also learned movements or skilled movements, and we will not be discussing the other two because they are not left parietal functions. But um, the misnomered ones are construction and dressing apraxia. These are primary visuospatial disorders. Then limb kinetic apraxia, oculomotor apraxia, these are disorders of motor or visual attention. And eyelid apraxia and gait apraxia, these are also not skilled or learned movements. Right? So limb apraxia, it is not rare or insignificant. It is frequently underdiagnosed. It is very common. Almost 80% of left hemispheric pathologists may have this disease, so may have apraxia. And like a stroke, after a stroke, the hemiparesis, motor deficit, the sensory deficit may recover, but apraxia frequently persists. And that's a lot of conditions cause apraxia, and it causes a major functional impairment and caregiver burden, because limb apraxia specifically or most prominently affects the hands and the fingers. And often the most important role on diagnosing apraxia is with rehabilitation, especially after stroke. So primarily occupational therapists do the diagnosis of apraxia, but it is a challenge when patient has apraxia, and the strategies for rehab will be based on the kind of apraxia the patient has. So Huckling-Jackson in 1860s he first described apraxia, but it was Lippmann in 1900. He published a series of papers in which he gave a praxis model, and it is still followed today. However, the condition or the anatomy and physiology of these praxis pathways are not still fully understood. So, but what we know is that left hemisphere is dominant for the limb praxis. The left parietal lobe plays a central role, and mirror neurons in the left. This is in experimental studies they have found mirror neurons in the left inferior parietal lobe. They deal with the learning of motor observed by observe motor. So the left parietal lobe mirror neurons, they learn motor patterns by observing and imitation, and they form and store the spatial and temporal representation. So basically, whatever motor act, skilled motor act we observe, the mirror neurons in the left inferior parietal lobe, they will form a spatial and temporal coordinate of the movement by observing, and it is stored as a code or a neural formula, neural representation formula, which is called as a movement formula. And since it deals with praxis, it can also be called a praxicon. Also, the left inferior parietal lobe also contains action, semantics, and conceptual systems. So these words may sound a bit scary, but they're actually very easy. Semantics is general knowledge about action in the skilled movement. So in skilled movements, we frequently use a tool. Like while brushing, we use a toothbrush, or while shaving, we use a razor or a shaving brush. So all of these tools, the general knowledge about when to use what tool and how to use the tool is action semantic, and the concept of that is called action semantic, right? So it deals with tool action, tool object association. Like a tool object association is like while driving a nail, you need a hammer. So that association between these two is semantic knowledge is stored by the left inferior parietal lobe. Then the general principles of tool use. So basically two components. One is a conceptual component and one is a production system, Praxis production system. So since Praxis deals with motor movements or the motor formula for a for a movement, skilled movement, so there may be a production error. Production error means the movement may not be spatially and temporally correct, so it will produce a movement error. But it is and also there is a conceptual system is the same thing again. It is about the knowledge of tool and object, the knowledge of action, or the organization of actions in a sequence. So if a skilled movement involves multiple steps, like when we brush, first we have to open the cap of the toothpaste, then lay it on the toothbrush, and then the third step is brush. So in the sequence, the knowledge about this sequence, all of this can be headed again under the conceptual system. And the actual transfer of this movement formulas to the motor areas, that is the praxis production system, right? So the errors resultant errors will be according to the system affected. So if the praxis production system is affected, the movements will be degraded, or the movements won't not be correct, and there will be a lot of spatial and temporal errors. So you'll get a clumsy, slow movement, which will not the patient. And on the other hand, conceptual system problem, the patient will perform a smooth movement. The execution will be okay, but it will be a wrong, because the wrong tool will be selected, or the correct the tool action, the wrong tool action will be performed. So that will result in a improper act. So it will not be clumsy, but it will not be correct. So what are the proposed steps in Praxis? So whenever there is a command for a patient, for example, if we command a patient by verbally, or verbally to show how to brush his teeth, right? This is a command or an input for the patient. Or we can give a visual command, like we can show him the gesture of brushing and ask him to imitate us. So these are inputs for Praxis. And these inputs, they will go from there. Suppose a visual input will go to the visual association area, and from there it will communicate to the left inferior parietal lobe, and there it will activate the movement formulas, or it will retrieve the movement formulas. After retrieval of the intent action, that is the movement formulas, these are transferred to the innervatory patterns. So these are movement formulas, these are codes which are transferred to the premotor area, that is the left sensomotor, that is the premotor area, and the supplementary motor cortex. So here the actual the actual signal to the primary motor area, that is the primary motor cortex, which will be sent from the premotor area and the supplementary motor cortex. This do the motor planning, and they receive the codes from the left inferior parietal lobe, right? So from there, the if the additionally, if the movement involves some tool or object use, then the action semantics, that is the knowledge, general knowledge about the tools, it will determine the tool selection and specify the knowledge of tool action. So what does the supplementary motor area do? It translates the parietal time space movement formulas to specific motor programs in the supplementary motor area, and that then further activates the motor neurons, that is in the primary motor cortex, such that the contralateral extremity moves in prescribed trajectory and timing. So this is how the Praxis execution system flows. So here we can see in the diagram, this is a verbal input, or there may be a visual input. If a tool is to be used for the skilled action, then the action semantics will be utilized, and it is localized in the posterior parietal. Then this is just close to the left inferior parietal lobe, but located a bit posteriorly. So this visual input or verbal input, they will go to the left inferior parietal lobe, and they will retrieve the movement formulas, whatever command the patient has received. And these movement formulas will then be transferred to the supplementary motor area, and they will determine the motor programs which the supplementary motor area will transfer forward to the left primary motor cortex for output in the right limb. And for the left limb output, it will transfer the information via the corpus callosum to the right supplementary motor area, and that will lead to the left limb output. So this is the Praxis pathway. Once we remember this, we can localize what kind of limb apraxia is due to which lesion, right? So we can classify this limb apraxia as per the, so in the definition we saw that apraxia, there will be either spatial temporal errors or there will be conceptual errors. So spatial temporal errors will be because of executive problem, and that is seen in these three apraxias: idiomotor apraxia, parietal variant, disconnection variant, or in modality specific dissociative apraxia. And conceptual problems will be seen in ideational apraxia and conceptual apraxia. So we'll see one by one which of all of these apraxias. We'll also discuss about limb kinetic apraxia and callosal apraxia, because these are also limb apraxias, though they are not true apraxias. So we'll also discuss them. So looking at this figure again, excuse me. So a verbal input or a visual input, it will go to the movement formulas, right? So first we'll look at A. So A over here is the left inferior parietal lobule, which contains the praxicons. So if there is a damage in the left inferior parietal lobule, the praxicons or the movement formulas will not be retrieved, even if we get an input from the visual verbal or visual modality, right? So the patient will not be able to, he'll know what, because he has received the input, he'll know what he is supposed to do. But since he could not retrieve the praxicons, the movement will be having a lot of spatio-temporal errors. It will be a clumsy movement, right? So if the lesion is at B, the same thing will happen. Even if the retrieval is done, it cannot be transferred. So again, there will be a lot of spatiotemporal errors. So this is called as ideomotor apraxia. Both A and B are called as ideomotor apraxia, though the location is different. So this is called the disconnection variant. This is called the parietal variant. Now this is again the same thing. Even if there is a disconnection here, it will be a ideomotor disconnection variant. Looking at C, if the verbal input to the inferior parietal lobe is gone. So if we command the patient verbally to do a action, particular action, like show how you will brush your teeth or how you will comb your hair. So this action will not, though he has understood the command, it will not go to his movement formulas, and there will be a retrieval deficit in the verbal modality, and so there will be again no recognizable movement. However, if the same patient is given a visual input, then he'll be able to do it correctly. So this is called as dissociation, modality specific dissociation apraxia. Again, this will produce an executive error or a spatiotemporal error, right? If the lesion is at E, so E is your action semantics. So if the action semantics area is impaired, then the concept of tool knowledge, tool object association, the general knowledge about using a tool is lost. So though the patient will be able to perform movements which do not require a tool, uh, uh, the actions which require a tool will be grossly impaired. He may use the wrong tool, or he may use the tool incorrectly, right? So that will be a content error. Though the movement will be smooth, the it will be a wrong movement. So that is a conceptual error or a content error. Now looking at F, so F is the corticospinal system. So it is a motor problem. It is not a true limb apraxia, but it will lead to something called as limb kinetic apraxia, which is a loss of fine finger movements or loss of dexterity. And this will also cause a lot of trouble to the patient, but it is not a true apraxia. It's a motor problem. If the lesion is as G, then the output to the right limb is normal. This pathway is all right, but the output to the left limb is gone. So there will be an isolated left limb output apraxia, and that will be a disconnection type of ideomotor apraxia. So everything from here will be ideomotor apraxia, disconnection variant. But if it is isolated to the left limb, so it is called as left limb apraxia. So looking at each of them in short, ideomotor apraxia, it is the most common and prototypical apraxia. It is due to damage to the praxicons or the connections with the SMA. These patients have impaired skill movement on command and as well as to imitation. They know what to do, but they don't know how to do it. So the execution is impaired, and the movements are not smooth. They are hesitant and stuttered. However, we can make out what he is trying to do. So they are basically very clumsy movements. So what kind of errors will these patients have? So these patients will have spatial errors. Spatial errors are like error in the improper posture, the finger and the hand configuration while doing the movement, or a body part as object error. So body part as object error is basically, since he cannot um, he cannot put the proper posture to his hand, and he doesn't have tool. When we are examining him, he'll try to substitute his body part for doing the movement. Suppose if he is asked to comb his hair, and he's told to not use his hand or a body part, he's told that while examining, he's told that you have to hold an imaginary comb and demonstrate the action. But these patients will still use their body part, and this is called as body part as objective, and this comes from the right parietal lobe. Since the left parietal is not acting, the right parietal lobe, which deals with the body parts, it will cause this error, right? So then again, the other errors will be correct orientation of the limb to the tool. So holding the brush in an improper way or the comb in an improper way. Then movement at joint. So suppose while using a screwdriver, the basic movement has to be pronation, supination at the elbow. But instead, the patient will try to use the movement at the shoulder joint. So it will the incorrect movement, right? Then the amplitude of movement. So there may be an error in amplitude. So these are all motor execution problems because of programming deficit. The trajectory of movement. So instead of brushing in this way, he may go in a very improper trajectory. Then there may be temporal errors. Temporal errors are like sequencing error. Sequencing error is not the same as a sequence in a multiple step. Sequencing error is like the sequence of the muscle activation during a particular act. Suppose while brushing it, first the elbow joint should move, then the shoulder should move. So this error in sequencing, alternate sequence, um, that error may be there. Then the timing error, the time taken, and the occurrence time. Now, what is occurrence type error? Occurrence type error is like when we ask the patient to do a action of opening a key, lock with a key. So this is a single action, opening the lock, right? But in these patients, there will be multiple attempts at opening the key, or he'll still try to continue doing that. That is called multiple occurrences. And some actions which require multiple occurrences, like a screwdriver or a hammer hitting on a nail, so there will be a decrease in the number of occurrences. So this is occurrence type error. So these are the typical errors in idiomotor apraxia. But what is the difference between parietal and disconnection variant? So parietal variant, there will be an additional difficulty recognizing or identifying gestures, and that is due to damage to the praxicon. So once they receive an input from visual, verbal streams, so they are supposed to this input is supposed to retrieve the praxicons. So whenever a patient is seen, suppose is given an action to imitate. So suppose we wave goodbye at him and tell him to imitate us. So this visual command, it has to go and retrieve the spatiotemporal movement formula, right? But since there is a damage in the left parietal lobe, this input will not be able to gather the or retrieve the spatiotemporal, and hence the patient will not be able to understand what the gesture was, because the understanding or recognizing the gesture is a function of this praxicons. So in the disconnection variant, it will be spared. So that is the chief difference between, and while testing the additional step will be done to differentiate between two. Conceptual apraxia, like we have already discussed, it is error in it is due to damage to the left posterior parietal lobe. It can occur isolated very rarely. Usually it occurs with idiom because they are neighbors, like in the neighboring areas. There will be no spatiotemporal errors if it is isolated, but there will be content errors. So what are the content errors? They will not know tool object action. They'll not know tool object association, like a key and a lock. The association between these two is lost. Tool selection. They'll, if given multiple tools, they'll not be able to select the proper tool, and loss of mechanical knowledge. So all this while testing, we can obviously make out, but actual impact of this on the patient in day-to-day activities is very significant, right? So conceptual apraxia is not a problem of praxis production, but it is a concept and knowledge loss. The patient is unable to name a tool. He cannot point to a tool whose function is discussed. He cannot recall actions associated with the specific tool. And there will be content error. They will substitute action associated with other tools for the requested tool. Gestures involving tools are impaired as well. But gestures which do not involve a tool may not be affected or mildly affected. Then we have already discussed what is a modality specific. It may be a visual or verbal dissociation apraxia. The only thing is it is an executive problem, but here there will be no spatiotemporal errors or content errors, but unrecognizable movements whenever the input is in that particular modality. And verbal dissociation apraxia is most common. It is also a disconnection between the verbal association cortex and the inferior parietal lobe. Then ideational apraxia. So this is a confusing terminology. It is like ideational apraxia and conceptual apraxia. Many times we get confused. So conceptual apraxia is about tools, concept of tools, and ideational apraxia is also about the concept, but about the concept of a sequence. Though it is a misnomer, but still we just have to remember this. It is an inability to correctly order or sequence a series of movements to achieve a goal. So multiple steps are involved in a particular skill, like using the toothbrush. First, you have to uncap the toothpaste and all. Those 3-4 steps are involved. Or mailing a letter or preparing a sandwich. So the patient is able to perform the individual steps correctly, but he will not know the correct sequence, and he may make sequence errors. He may altogether skip a step, or he may do it randomly. So the act will be disturbed. And usually this is seen with diffuse processes like extensive left frontal and supplementary motor area lesions, like in dementia and delirium. So it sounds a bit like executive dysfunction, in which sequences multiple steps are involved, but the patient will not have other deficits of executive dysfunction like planning, monitoring. Limb kinetic apraxia is not a true apraxia. Again, it is a loss of dexterity due to primary motor cortex, or some books say it is a premotor cortex problem. And it can be right or left-handed. It is not like true limb apraxia. It can be either right or left-handed, depending on the location, contralateral lesion. Now, one more limb apraxia is callosal apraxia. So in callosal apraxia, it affects only the non-dominant limb. The true callosal apraxia affects only the non-dominant limb. So it may be a left hand idiomotor apraxia disconnection, which we already discussed, or it may be a left hand verbal dissociation, which has been like few case reports have been there of a specific verbal dissociation apraxia affecting the left hand. But one more interesting, and which is not a apraxia as such, is the callosal alien hand. So it has been also misnamed as a apraxia. So we'll be discussing. It is a diagnostic dyspraxia, not apraxia, it's dyspraxia, sorry, or intermanual conflict. So the limb, what happens in this is the lesion is basically in the frontal, medial frontal, as well as the anterior callosum, and the limb feels foreign. So the pathology is basically the right non-dominant hemisphere, which deals with the body schema or the body parts. So it is disconnected from the left side. So the left limb feels foreign, and it has involuntary semi-purposeful movements, because patient has no what is control over that limb. In addition to, and it performs these movements in addition to or instead of a planned or willed movement. So if it performs independent movements or opposition movements of the left hand, and it is often to the surprise of the patient, it is called diagnostic dyspraxia. So opposition movements are like, suppose the left hand is asked to perform an act, so he'll do exactly diagonally opposite act to that. So we'll learn that in the testing part. Or sometimes they may even do what the right hand is trying to do. They'll try to do exactly opposite act to the right hand. This is called as intermanual conflict. Right? So it is due to a combined anterior callosal and medial frontal prefrontal lesion. So how do we test limb apraxia? First and foremost, we have to rule out significant impairment in sensory, motor, and cognitive domains, which we have already discussed, because this may interfere with the skill performance of skilled act. So we need to know what is transitive movement. Transitive movement is a movement involving tool or object. Intransitive movement is a movement with gestures, communicative gestures. Pantomiming is like mimicry, miming. So it is by portraying by gestures and bodily movement. So whenever the patient is given a command to pantomime, he has to perform that command by gestures and bodily movements. And imitation is copying what we show to the patient. So examination of the limb apraxias. So non-dominant, first of all, we have to examine the dominant upper limb and then the non-dominant limb. Both limbs have to be examined. And there are 7 steps in the examination. This is from Bradley's textbook. You can have it from other textbooks also, but I usually follow this and it's easy to remember. So first of all, the first step is pantomime to verbal command. So he has to show by gestures or mimic whatever command we give verbally. So for this, first we give him transitive, like tool containing actions, like ask him to comb hair or show how he'll comb hair or brush his teeth. But first we have to instruct him not to substitute their fingers or body parts and pantomime using a pretend tool, right? So any 2-3 actions you can ask. Then after that, we have to in these actions we have to look for spatiotemporal and content errors, which are classic of idiomotor apraxia. Then after that, we ask him to do intransitive actions like wave goodbye or beckon someone to come, show the okay sign or the peace sign. So this is how we'll check the the actions not involving tools, right? Then again, this will show if there is idiomotor apraxia, they will show spatiotemporal errors. Um, this is pantomime to verbal command. So this is an auditory input. Then the next step is check for visual input. So for this, we have to ask him to imitate the gestures. So we demonstrate him the same gestures and ask him to copy them without naming them, right? So the same transitive actions and intransitive actions have to be shown to the patient, like waving bye bye or demonstrating how we'll comb hair, and ask him to copy that. And this will test the visual input. Again, if there is idiomotor apraxia, we'll get spatiotemporal errors. Then the next step is gesture knowledge, and this step will also rule out any dissociation apraxia, because this is verbal and this is visual input. Then gesture knowledge. Again, we already discussed gesture knowledge is a function of parietal, inferior parietal lobule. So if there is ideomotor apraxia and gesture knowledge is impaired, that means it's a ideomotor parietal variant. And if it is preserved, it is a ideomotor disconnection variant. So this step is important. And gesture knowledge, we demonstrate different action and ask the patient to identify their purpose, as well as we ask them how well will they perform. So the knowledge is not just about identifying, we are able to tell which one was performed in a nice, more correct way, and which was not correctly performed or badly performed. So this is how we check this. So idiomotor apraxia will find this spatiotemporal errors leading to a hesitant, stuttered movements, not smooth movements. But the goal we can determine. If the pantomime is impaired, test imitation. One point I missed. In imitation testing, we also have to check for meaningless gestures. So meaningless gestures, now it is not a skilled movement, but copying a meaningless gesture will test the visuospatial abilities, and it is a test for right parietal lobe. It is not a test for left parietal lobe. So meaningless gestures, like you can ask him to um, interlock his little fingers like this, or ask him to touch with his thumb on the nose, left thumb on the nose. So that will be a meaningless movement. And if he is able to do that correctly, that means the right parietal is functioning properly. Then gesture knowledge we've already seen. Distortion apraxia. Okay. The next apraxia that we test is sequential actions. So sequential action is for, like we already discussed, for ideational apraxia. And in this, we have to give him a task, pantomime task where there are multiple steps involved, like later for mailing, or a sandwich for eating, or how he'll prepare tea if it's a female. So we have to first instruct the patient that the imaginary elements needed for the task are laid out in front of them, and then ask them to use those two imaginary elements and demonstrate how they are going to perform it. And if they skip a sequence, or if they alternate the sequences, then we can diagnose ideational apraxia, right? Then conceptual knowledge about tools and action of the tools. So for this, the examiner shows them pictures or the actual tools and ask the patient to again pantomime the action or use. So there are different tests that we can do. This is the first one. First of all, we have to rule out anomia and agnosia while testing. So for anomia, we'll have to ask the patient to name the different tools that are present. So in anomia as well as agnosia as well as apraxia, the patient may not be able to, if he has lost the concept of this, he will not be able to name it. But in anomia, he will be able to describe the use of the um, like if suppose we show him what is this, this is a hammer. So he's not able to name the hammer, but he's able to describe it use, then it rules out. uh, and agnosia will be a modality specific. So if he's not able to recognize by seeing, we can ask him to describe the features of that object what he's seeing. And if he's not able to still recognize, we can give it in his hand, the real object, and then he can recognize for visual agnosia, right? And in apraxia, the patient will be able to tell the features of the object, but he'll not be able to tell the name or the function, right? So this is how we'll differentiate between the three of them. So tool selection, first test is tool selection task. So we show him a figure of a nail which is partially driven into a wooden plank, and we ask him, out of these objects, which one will you choose for completing the act, right? We do not have to give any hints. We just tell him this is a nail that we have to hammer, and not hammer. This is the task that you have to complete. Drive the nail into the wood. Which of the tools will you use? Excuse me. So the patient with an conceptual apraxia will not be able to tell the correct tool, right? But we give him another test. This is an alternate two selection task. In this, again, the same picture is shown, but the hammer is removed from the pictures. And then the patient is asked, which tool will you use? If even if the hammer is not there, one of the tool, that the spanner, we can use to hit. So this tests the mechanical knowledge or the concept of tool advantage to the movement of a skilled movement. So basically, tool provides a mechanical advantage in performing learned skill tasks. And even if the real tool is actual tool is not available, if the patient has some mechanical concept or knowledge, he can use an alternate tool, or he can use a stone to fix the nail. So this is how we'll test the alternate tool selection task. And the easiest step is this: just ask him to describe the use of the tool. So since he has lost the general knowledge of the tool, he'll not be able to describe the action. In this, we have to look for content errors during this conceptual apraxia. Um, Content errors will be like wrong action of the tool, wrong tool selection, but performance will be smooth. Excuse. So this is a summary of what will be the abnormal findings. You can use a mnemonic that I use: pigs see left right, PIGS, pigs see left and right. So you can use any other mnemonic. So because you have to go step by step in this apraxia testing, and try to perform it on most of the higher function case. So testing callosal apraxia, which is not a true apraxia, or the alien hand. So intermanual conflict, that is opposite actions of the left hand and the right hand. So in this, you ask the patient to answer the telephone by picking up the receiver with his right hand. Then uh, while his right hand reaches for the receiver, the left hand may interfere with the right hand's action and actually try to put the receiver down. So this is a exact opposite action. This is called as intermanual conflict. Again, you can pantomime to command, ask him to do a gesture or do some action with the right hand, and the left hand will interfere with that. Or simplest way, ask him to perform a bimanual task like tying a shoelace. Again, the right hand is trying to put on the shoelace, but the left hand is trying to remove it. There are other tests also, but these two, three are sufficient. Then diagnostic dyspraxia is like when the asked to pull chair forward with left hand, then the patient's arm will left hand will actually push the chair backward. So diagonally opposite action. This is called as diagnostic dyspraxia. This will always be in the left hand, remember. Then the next left parietal syndrome that we are going to discuss is Gerstmann syndrome. So this is a very fascinating syndrome. For many years, people have been fascinated because seemingly unrelated dysfunctions are seen, but actually they are quite related to each other. So we'll just discuss one by one: finger agnosia, left-right disorientation, acalculia, and agraphia. Often they also have alexia, anomia, and apraxia, but these are not a part of the syndrome. And the lesion location is in the angular gyrus. So left inferior parietal lobe, angular gyrus is the most important, with or without the supramarginal gyrus, and with left occipital extension, or there may be a subangular gyrus involvement with forceps of the splenium corpus callosum, but angular gyrus is always involved. So these are the functional mapping studies and diffusion tensor imaging studies. Here you can see actually the left angular gyrus over here, but the site of the lesion or the mapping where the activation has occurred are different. So overlap studies, they are found they are different, and the diffusion tensor imaging also shows different fiber tracts. So though they are localized in the left angular gyrus, they are not subserved by the same cortical neurons, right, or the same pathways as well. But finger agnosia is an inability. We all know agnosia is a recognition disorder. So inability to recognize fingers independent of any sensory modality. So we talk about visual agnosia and tactile agnosia. These are modality specific, but finger agnosia is specific for fingers independent of any sensory modality impairment. So initially it was described by Gerstmann as inability to recognize fingers even in full sight, right? In the absence of autotopagnosia and aphasia. Autotopagnosia is ignorance of body part or denial of owning their own body parts, and aphasia. So this was what he described, and but there is still a lot of variability. And now the newer studies say, most of the new studies will say there is mild or no impairment when the fingers are visible. So this is in contradiction to what Gerstmann observed. So that the impairment evident in naming the touched finger or in pointing to the named finger when out of sight. Usually it is evident when out of sight. Then it involves the middle three fingers more often. So the peripheral fingers like the pinky and the thumb, they are not more often involved because they may be getting some proprioceptive clues or something. Right. So that's why the middle three fingers should be specifically tested, and it extends to the toes as well. So it's not just finger; it is also toe agnosia. And to differentiate it from finger anomia, so the tests that that we are talking about, naming the touched finger or pointing the named finger, these all involve language. So to differentiate from finger anomia, non-verbal tests, although naming is involved, so non-verbal test must also be applied, which will not involve naming the. So this is how we differentiate finger anomia from finger agnosia. And only 20% wrong responses are also sufficient to say finger agnosia. So so you can just do one or two tests. You'll have to do multiple responses, touch multiple fingers, and then certain whether finger agnosia is there or not. So there are a few tests for that. First, we have to test with eyes open and then with eyes closed. So with eyes open, and even if the patient is still the patient is impaired, then it is quite severe. But if to be more sensitive, we have to have the eyes closed. So verbal tests. Um, First, like we have already discussed, name the touched finger. So the examiner touches the patient's, suppose the index finger, and asks him, "What is this finger?" And he has to name it. If he's not able to do that, then we call it as finger agnosis. Then again, point to the named finger. So first, we tell him point to your thumb, or point to the examiner's named finger, like point to the examiner's index finger, right? With eyes open and then with eyes closed. Then non-verbal tests, these are for ruling out anomia, and these are quite much more sensitive to pick up finger agnosia. So these are the more important tests. The first test over here is in-between test. So this initially interested many people. So in this, the hand is given and the hand is touched at two different fingers or on the same finger, and the patient is asked how many fingers are in between the touched fingers. So suppose I've touched these two fingers and there is no finger in between my two fingers, so the answer will be 0. If I touch it this way, the answer will be 1. So this involves numbers like calculation or the concept of numericals. So in Gerstmann syndrome, this may be impaired, and that's why the interest in the in between test has faded. So rather, the other three tests are used nowadays: 2-point finger test, homologous finger test, and the finger strip test. So this A is the finger 2-point finger test. This does not involve numerical responses. So these are more specific, right? So in this, you can see on two finger test, the fingers on one hand are touched in two places by the examiner, and patient judges if the touches are on the same finger or different finger. So the response of the patient should be same or different. So in the first figure, you can see here the same finger is touched, and the patient will answer if he is not agnosic, so he'll answer the same. In this, he'll answer different. In this, he'll answer different. If he's impaired, then we call it as agnosia. Is if the index finger of one hand is touched, and all of these tests are done with eyes closed, right? So if this index finger is touched on one side, then the patient has to move the index finger of the other side. So this is the homologous finger test. So here you can see the index finger and the response is here. Again, the ring finger is touched and the response, sorry, the ring finger here is touched and the response is by moving the ring finger on the other hand. And the finger strip test, 5 strips are provided to the patient, which are labeled with the names of the fingers, that is thumb, this over here. All the 5 fingers are labeled, and the patient has to arrange in the order on our hands. So this is how finger agnosia can be detected. These are not dependent on naming. So right left orientation. Now right left orientation is the ability to identify the right and left side of one's own body, as well as a person seated opposite, or in a picture or a drawing. So basically it is a spatial function related to language. So it to the person himself or extra to the other person or to a drawing also. So we all know there is a role of right parietal in body schema and knowledge. However, the special function mediated by language is dependent on the or is performed by the left parietal. And these patients not only fumble with right or left, they also fumble with spatial relations like up, down, over, under, above, below. And tests using two-stage commands or examiner is seated in front are more sensitive. So we'll just come to that. What are the tests for right left orientation? So first we test the orientation to the patient's own body, then orientation to the person or sitting in front of him or the picture or drawing, and then combined orientation can be checked. So first step is for own body. First we ask the patient to name the single lateral body part touched by the examiner. So ask him to you touch his left hand and ask him to tell what what was the part that I touched. then point to the um, single lateral body on verbal command. So we can ask him to show me your left hand or show me your right, but these are not sensitive tests, and this may not more specific, rather not more specific, because the patient can easily answer them and still be abnormal on for other tests, more sensitive tests. So the more sensitive test would be double uncrossed movement or double crossed movement. So double crossed movement is more sensitive. So for double uncrossed movement, we ask him touch the left ear with left hand, and crossed movement left ear with right hand. So the last one is more sensitive. Same way we ask him to on confrontation of a person or picture drawing. Only here he has to imitate the double uncrossed movement of the examiner or crossed movement of the examiner. So these are more sensitive. And combined test is place your right hand on the confronting person's left ear. So both the subject as well as the examiner are involved. So these are the more sensitive tests. Primary acalculia or anarrhythmia. So calculation basically is a very complex cognitive process, and multiple domains are involved in its performance. Like concentration should be there, otherwise the patient may miss a symbol, addition, subtraction. Then the language is important for reading what is the digits as well as the written problems. Then spatial function for arranging or arranging the letters for adding and subtracting the larger numbers. Then memory is important for remembering the formulas. Visual recognition of numbers is important. That is there should be no agnosia. And executive function, whenever there is a multi-step problem, or whenever planning and problem solving is involved. So we'll come to the examples later. So but out of all these are all domains which can be causing a impaired calculation, but most basic is a knowledge of numerical concepts or computational skills. Just like how praxis is a learned skill which comes after like with age it comes, that similarly numerical concepts is also a skill which is determined by the left parietal lobe angular gyrus, and this will also develop with age. So a calculator definition is loss of ability to perform calculation tasks from acquired brain injury. And primary acalculia is acalculia because of impairment in computational skills. That is the concept of computation or numerical skills. And secondary acalculia become because of many other domains which can cause secondary acalculia, but that is not called as anarrhythmia. It is secondary acalculia. So we'll discuss one by one, but first we'll discuss what is numerical concepts. So numerical concepts is basically number representation in the brain. It follows triple code. So the numbers or the are represented in brain in either an abstract quantity, that is a non-symbolic quantity, well, like large versus small collection. So a person can make out looking at this diagram. This is a smaller amount than the this one, collection than this one, image in B. So this is called as abstract quantity. This is non-symbolic, and symbolic is digit format or word format. So this digit format is encoded by the bilateral fusiform gyrus. It is not dominant on one side, but the word format is in left angular gyrus is dominant for that. And for abstract, the horizontal intraparietal sulcus on the left and right, both sides are involved. And what is transcoding? Transcoding is translation of these three formats into one another. And this is used in various combinations for doing the actual arithmetics. Right. So these are the three areas. First is the left fusiform gyrus, which is involved with digit input. The angular left angular gyrus, which is involved with word format input, and this is the horizontal intraparietal sulcus, which is involved with abstract quantities. Now what is the levels of numerical knowledge? So this is an important concept to understand, because I'll just come to that. So whenever a person is born, he already has this global quantification, that is abstract quantification abilities are already there. This is also found in animals, and in the prehistoric man also it was there, and this is pre-existing. So enumeration, then as the child grows, he'll start enumerating. He'll call the objects as this and that. Then later on he'll this left parietal lobe, the skill will be developed. So correspondence construction, this is like matching externally with external objects, like counting with pebbles that the prehistoric man used to do. So there are 10 apples, then he'll count with 1 2 3 4 5 like this. And then but the child will start using his finger, And this is the connection between finger and calculation. So finger gnosis, knowledge, and calculation. So that's why they are co-localized. Then counting, then later on they'll start counting 1, 2, 3, 4, and like that. Then the 1 1 principle. So each, suppose there are 10 apples, so then the child will call, this is 1 apple, this is another 1 apple, this is another 1 apple. So everyone will be called as one item. This is the 1 1 principle. Then there is a stable order principle. Stable order principle is that every number will have its own designation. Like if there are 10 objects, then number one, first object will be called number one, second object will be called number. It's like roll number. So the number will denote their identity. And cardinal principle, later on they learn the cardinal principle, that is, in a object series, the last number on counting will be equal to the quantity of the number. So these are all basic uh, numerical concepts. And the last one to that we learn, or as we develop the skills, is arithmetic. Arithmetic is addition, subtraction, division, multiplication. So what is the importance of this numerical concepts is that in left parietal or angular gyrus lesion, these numerical concepts of counting and the 1 1 principle and arithmetics, these are the affected, and this lead to the acalculia, and while the other cognitive domains will not affect these numerical concepts. So primary acalculia is acquired deficit in understanding of this numerical system that we just discussed. Deficits are in using the rules of calculation. So they will be very grossly impaired. They will not know any rule, like how to add, how to subtract. They'll not even understand the numerical signs. Like if the plus symbol is shown or a division symbol is shown, they'll not understand. They get confused with numbers and signs. Then there is a global quantification that is relatively spared because it is not a part of this numerical concepts. However, basic principles of counting are impaired. Like counting will be impaired mildly, but grossly impaired will be the later acquired skills, like arithmetics and problem solving. Both written and verbal will be grossly impaired. So alexic acalculia, the secondary acalculias, we'll just discuss in short. Alexic acalculia is that patient will not be able to, there will be two, either alexia with agraphia and alexia without agraphia. So with alexia with agraphia, he'll not be able to read the written numbers and signs. Written calculations also, because of the agraphia, will be grossly impaired. However, the mental calculations will be better. Um, then without agraphia, the same things, the lesion location is different, but there will be more difficulty with words, because the words are what is it, the left side of the brain is left parietal is dominant for words, while digits are represented bilaterally. So more difficulty with words will be there, and the compound digits will be more difficult to read. So this basically, these patients also read letter by letter, and also read the digits digit by digit. So if there is a 332, they'll read it as 3 2, like this. They'll start reading digit by, they can't read 32. Then writing and however is preserved, and mental arithmetic again is and counting is again spared. Then spatial acalculia, it is due to visuospatial deficit. So the visuospatial right parietal pathology, there is inability to align numbers in columns. While adding large numbers or subtracting large numbers, they cannot arrange them in the proper columns. Then there will be difficulty with written arithmetics, which will be much more problematic. There will be overuse of the right half of the page. There will be visual neglect, and there may be errors in visuospatial errors, like 227 may be read as 22277, inversion 6 may be read as 9 or written as 9. Then there will be reversal errors, 32 will be read as 23, and complex number reading may be impaired, like they've missed this zero and the quantity of obviously has changed. So however, these patients will be better with mental arithmetic, and counting will be normal. So aphasic calculus is like similar to the reading defects with these patients. Broca's, there will be syntactic errors, like grammatical errors. They cannot transcode, so there will be difficulty in transcoding. They cannot read the hierarchies like 300,200. This is 3 lakh 200. So they will not be able to read this, understand the significance of this 100 and this 100. They'll get confused with this. So the syntax is involved in understanding this written sentence. Then stack errors. The 14, they'll ignore the tin, the additional tin, and they'll just write 4. This is Broca's. Wernicke is again similar to the reading and writing errors. There will be paragraphia, paralexia, for numbers like 257, like confabulation and jargon, they'll read it as 257 as 252, 37 as 27, like that. So these are not basically primary calculation deficits. And frontal dysexia, this is the more common that we usually see in day-to-day practice. So frontal or dysexecutive acalculia, here the solving of problems which requires manipulation of concepts as well as working memory, this is grossly impaired. So if we give them a new mental problem like how will you arrange this number of items into this and this, so this is a mental problem for solving, and this will be grossly impaired because working memory is involved and executive function is involved. Then wherever multiple step calculations are there, they'll be more affected. Then open-ended series like serial sevens, 100 minus 7, they'll answer correctly 93. But then the perseveratory errors start. Then the next thing they'll say 83, then 73, then 63. These are the perseveratory errors. Then elementary arithmetic, like simple calculations, they'll be relatively spared, even written. However, mental arithmetic is much worse because it requires holding the information for a short time. That is, it requires working memory, and that's why mentally they will be worse. Mental arithmetic will be worse. How do you test calculations? First, you rule out alexia and agraphia. For this, you give them to read a simple series of numbers or a complex, and then a complex series of number, and ask them to read. So this will rule out alexia if they read it correctly, and then ask them to write numbers to dictation, and that will rule out agraphia. So then later on the actual steps of calculation, forward and backward counting. So ask them to count from 1 to 10 or 1 to 30, and ask them to count backward from 30 to 1 or 10 to 1, whatever. And then this is how the numerical concepts will be tested, that is of counting. Right. It tends to be spared in the secondary acalculias, but it may be affected in the primary acalculia. Then symbolic transcoding, 109 2. Then he has to write it in digit figure 109, and 283 he has to transcode it into the word format. So this may be error in either in the aphasias or in the alexias or in the calculation, but they will be spared in the primary calculus, right? Then reading and writing arithmetic symbols, this is tested. This is again for alexia and for the reading and for the concept of these symbols. So this will be grossly impaired with primary calculia. Then mental calculations, this will be more impaired in for mental calculation. You give them single digit as well as double. The books mention double digit, but usually you start with single digit. um, this will be more impaired in frontal, but also in your primary acalculia. Then written calculations, this will be grossly impaired in agraphias and language disorders, and also in your visuospatial errors, because if you give them double and triple digits, they'll not be able to align the numbers for doing the figure calculation. Then align numbers in column, just give them a series of numbers and ask them to align it for adding or subtracting, and then the alignment error, that is the visuospatial errors, will be more evident. And arithmetic problems requiring planning, like example, arrange these 6 bananas in 2 shelves such that one shelf has double the a number in other shelf. So this is a this requires some mental calculation as well as working memory to hold. So this will be grossly impaired with your frontal disexecutive. And this is how we test calculations. And the simple method and comprehensive method can be just ask him to write down a large 4-digit and a 3-digit number, and ask to add or subtract, putting the appropriate why large 4-digit number or a large 3-digit, so that there will be some carrying over to be done. So you give a large number, and most of the steps will be carried out, like transcoding will be done into a digit format because it's a verbal command. Then writing arithmetic signs will be involved, then aligning the numbers in that column, then carrying over will be done, and the written calculation will also be tested. So it's a comprehensive and a simple method for testing. Now come to the right parietal lobe. Right parietal lobe, the functions we all know, and I'll just spatial orientation, that is orientation of the person in the space around him, also of the objects in the space around him to one another and with respect to the patient. Then body schema is knowing his own body parts. And topographic memory, that is the ability to navigate the surroundings. These are all functions of the right parietal lobe. And lesions here will produce hemi neglect, constructional and dressing apraxia, Asomatognosia. Asomatognosia means denial of or loss of knowledge of their own body parts. Asomatognosia or anosognosia. Sorry, anosognosia is denial of illness. This is also a right parietal function. And topographic disorientation. We'll look at this one by one. So neglect. Neglect is lack of orienting responses to unilateral novel stimuli in either auditory, visual, or tactile format, and in the absence of a primary sensory or motor deficit. So this lack of orienting responses may be because of either a motor or a sensory problem, that is an attention problem or an intention problem. So the sensory problem is called as hemi inattention, and the intention component is called as hemiakinesia. It is a multi-component disorder, and it can involve only it can involve one side of the body of the person himself, that is called personal hemi-neglect, or the peri-personal space. Peri-personal is within reach of the person, or the extra-personal space that is beyond the reach of the person, like in a room or the external environment. And it can involve in a varying combination. So you need to test all three of this. The basic concept is that neglect. First, you need to know sensory inattention is basically modality specific. It is due to a lesion of the unimodal association cortex, like visual inattention or tactile inattention. But when there is a sensory multimodal association cortex, that is a right parietal lobe is involved, then there is a space, neglect of the space, and all the modalities may be affected. So tactile, auditory, visual, all are affected, and that's why it results in a hemispatial neglect. It's a perceptual sensory deficit. And lesion of the motor association cortex or its subcortical circuit, like the frontal lobes and the subfrontal circuits, this will lead to motor neglect, including the basal ganglia also will lead to motor neglect. So neglect, why it is more common in non-dominant hemisphere lesions? Because the inferior parietal, we all know inferior parietal lobule or the frontoparietal circuits, they will sculpt the attentional landscape, the subjective in reference to the person, the space around him, the attention to that space, the stimuli coming in that space, it is determined by the inferior parietal lobule. And non-dominant hemisphere mediates attentional mechanisms for both hemispheres, right as well as left, whereas left is concerned only with the right. So lesion of the left is still counterbalanced by the right hemisphere, which looks after the right hemispheres also. But that's why we get neglect or a hemi neglect more commonly in the left side, but motor neglect can be either side. So hemi neglect is a phenomena of neglecting one half of the body or the external space. It may be personal hemi neglect, which is directed to self, which can be either motor personal hemi neglect, that is underutilization of neglected limbs. So if the left limbs are neglected, he will not use the neglected limbs. Instead, to perform tasks on the left side of the person, like suppose a cup is kept on the left side of the person, and he needs to pick it, he's asked to pick it up, he'll not use his left hand which is nearby, but he'll rather bring the dominant hand to lift the cup. So this is an example of motor neglect. Especially these patients will have bimanual tasks will be severely impaired. And the localization, as we discussed, it is frontal lobe and the basal ganglia, basically the premotor frontal areas and the basal ganglia. So premotor or directional action neglect. What is this? Directional action neglect. So in this case, the unimpaired side, that is the right side, they will not perform the work, or they'll neglect the neglected side of the body. Like because his left side is already having a neglect, it is underutilized. But the right side will not help it by performing tasks on the right side. Like while shaving, they will try to neglect the left side of the face, or while combing, they'll also neglect the left side of the face, hair, left side of the hair. Then asomatognosia. This is also a type of neglect. It is disturbed feeling of ownership of the contralesional limbs that we have already discussed. Then somatoparaphenia. This is delusional misidentification of body parts. So these patients may actually not identify their limbs as their own, and identify them as somebody else's, or they may identify others' limbs as their own limbs. This is a delusional misidentification. This is because of additional lesions in the medial or frontal. So these are seen. These are the personal hemi neglects. What are the tests for personal hemi neglect? Motor neglect by asking bimanual tasks, like linking pinkies is a bimanual task. So the right will go for that, but the left limb will not cooperate. And holding an object. Then premotor and directional action neglect. So that is the right hand, which is the unimpaired hand, is not helping on the left side of the space. So ask him to gesture how they shave or comb or put on a makeup. So they'll only demonstrate these actions on the right side. And even on the history, you can make out they'll not put on the clothes on the left, they'll not shave their left side. Then asomatognosia, you can ask them for their deficit, what is their deficit, and they may deny that. That is for anosognosia. And for asomatognosia, they ask them about the existence and ownership of the whose limb is this, and whose limb is the examiner's limb. Show him the examiner whose limb is this. So they may deny this. They may show this somatoparaphernia or asomatognosia. But the best test for personal hemi-neglect is the fluff test. So in the fluff test, the person has 24 velcros, this A to L, 24 A to Y, 24 velcros are attached to the person's body after blindfolding him, and 3 on the right side of the torso, 3 on the left side of the torso, 6 on the right lower limb, 6 on the left lower limb, and 6 on the lower limb. And the unimpaired hand, it is the patient is given the command to remove the velcros from his body. So remove all the targets using the ipsilateral hand. And but the patient should have good compliance, as well as the language should be intact. The patient will only remove the velcros from the right side, and he'll neglect the left side if there is a left hemispatial neglect. The drawback is it still cannot differentiate between motor and sensory neglect, because we are only using the right hand. Then the more common type of neglect is extrapersonal neglect, which can be either peri-personal or it can be extrapersonal. And then third type of neglect is representational neglect. Representational neglect is from a memory. The patient is asked to do a figure or a diagram, and then he'll neglect the left side features of that representational drawing, like a clock or his home. So we'll discuss one by one. Extrapersonal neglect. The best test for extrapersonal neglect is line bisection test. The best test is visual search test. The line bisection test actually has a sensitivity only of 60%, while the cancellation test, visual search test, this have a much higher sense, more than 90%, or the Bell's cancellation test. So we'll look at them one by one. So this is the line back. The instruction to the patient is A4 size paper has to be taken, and a long line has to be drawn, at least 18 to 20 centimeters, and it has to be placed right in front of the patient's vision, center in the midline of the patient, and then ask him to bisect it in the center, or mark it in the center. So a normal person will do it correctly, like shown in the figure 1. But a patient with left hemi neglect, since he's neglecting the left side of the line, he'll put it in the middle of the right side, right half of the line. So this is in left hemianopy. On the other hand, left hemianopic patient is aware of his deficit, visual deficit, and he'll try to move his head to look at the left side of the line, and he'll bring his right visual field to the left side, and he'll forget the right side. He'll not be able to perceive the right side of the line, so he'll have a leftward bias, right? Then the next test is visual search and target cancellation test. So it can be using alphabets or shapes like a star shape, or you can also use bells. So in this test, the patient with a hemispatial neglect will neglect the left side completely. He'll only cancel the task on the on the right side. And one important clue is that he'll start his search from the left side, right side, and go to the left side when he's doing the test. On the other hand, a normal person will always, who reads from left to right, will always start his search from left to right. So this is a good clue in this test. And this has a very high sense. So this can be considered the best test. Then copying symmetrical drawings, like in this side you can see this flower pot with two headed flowers. So he has neglected the left side of the image in this drawing, patient with left hemi neglect. And this, they may omit or incomplete the left half. So they may do it, but they'll not do it completely. Then what is object centered neglect? So when 3 different drawings are given, symmetrical drawings are given, in each of them he has neglected the left side of the drawing. So this is object centered neglect. So this gives us an idea that the neglect is actually not only for the left hemisphere, it is actually a neglect for the mental representation of the object. So when he looks at this object, the left side of this object, the mental representation in the brain, he'll neglect the left side. So this is called as object-centered neglect. Then marking objects in a room with risk. So his patient is seated in the middle of the room and asked to report 10 different objects around him. So he'll report objects only on one side of the room. In fact, hemianopics will compensate by moving their head and search for the other side as well, because they are aware of their deficit. Constructional apraxia. Again, constructional apraxia and dressing apraxia, these are complex tasks which are impaired because of the visuospatial deficit in a patient with right parietal lobe lesion. So constructional apraxia is a impaired motor performance due to perceptual difficulty, inability to put together different parts of a spatial array. So when there is a complex array or spatial array, then there will be the relation between them will be difficult for the patient to draw. So right parietal, the patient maintains the structural complexity of the drawing, but it is incoherent and disjointed because of this impaired spatial relation. They tend to neglect the display hemispatial neglect as well, neglect the left half, and they tend to orient the paper, orient the drawings diagonally to the paper. So we'll look at the tests for this, but we also need to know left parietal lobe patients will also have constructional difficulty, which is what they will draw slowly and with difficulty, and they will actually oversimplify the drawings, and they will trace lines perpendicular to ones already present. So we'll just look at an example to get a clue. So how do we test for constructional apraxia? We ask them to copy a simple two-dimensional drawing like a Greek cross or a square or a circle. Then we ask them to copy a complex two-dimensional drawing like intersecting pentagons of the MMSC or the clock face, and then three-dimensional drawings like Necker's cube and house. So this is the example one. In this, the Greek cross has been copied correctly, but the three-dimensional drawing, this is the harder one. And look at the patient's drawing. The left side, right side, he has tried to put the details of the drawing, but the left side is totally ignored. So this is constructional apraxia. Then you can use this three-dimensional Necker's cube or the overlying lapping pentagons. This is an example from Brazil, and this is a Necker's cube and the house drawing, which the patient was asked to draw, and the patient with left side lesion has oversimplified this Necker's cube, right? And there are a lot of straight lines to the one which he has already drawn. So a lot of right angles in this figure and a simplified drawing. But a patient with right side lesion has drawn a complex drawing on the right side. The three-dimensional drawing is there, but left side is totally neglected. So this is right side, the right parietal lesion. Same in the house diagram. And there is no right angle lines in this. There are a lot of diagonal drawings on the patient with right-sided lesion. Again, oversimplified house and a left side neglected house with diagonal lines. Here you can see perpendicular lines. Here they are diagonal lines. This is a good example of constructional apraxia. Excuse me. Excuse me. So dressing apraxia. Again, it is because of visuospatial difficulty, impaired tactile and visuospatial coordination, and hemi neglect. We'll explain this dressing apraxia. Patient cannot orient items of clothing to themselves, and there will be striking difficulty to wear clothes. How do we test it? By asking to put on a jacket given upside down with sleeves turned. So make it upside down and sleeves turned inside out. So, and the patients will be very grossly. Most of us must have seen many times. Then topographic orientation. Now the concept of topographic orientation is that ability to see, become familiar and orient in the environment. That is the navigational ability is called orientation, topographic orientation. And when we are not able to find our way in the surrounding, this is called topographic disorientation. For this, the cognitive map is essential. So cognitive map concept is that egocentric representation and allocentric representation. What is egocentric? Localizing objects and immediate environment with respect to one's own body. And whatever the person is visualizing right at the moment. And allocentric is what he has seen in the past and representation of that environmental survey, which is not visible, but it is stored in his memory in the hippocampus and the parahippocampus. And the egocentric is a function of the right parietal. Allocentric representation is a function of the parahippocampal gyrus and the hippocampus. We'll just look at the concept. Role of parahippocampal gyral place area for formation of allocentric representations of novel stimuli, that is antegrade topographic memory, and which is stored as in the hippocampus as long-term navigational memory. Eventually, after repeated stimuli, it will be stored in as long-term memory. The hippocampal place and grid cells are active. This is a recent discovery. These are active during actual navigation. However, the offline information is stored as either a landmark representation in the lingual gyrus, Landmark representation is for famous places or a home of the person. And survey, this survey is a representation allocentric, that is what he has seen previously and stored in his parahippocampal gyrus. And this can be utilized for navigating when we step into that new environment or the one in which we have already stored. And root is egocentric representation of visible objects. This is the function of the right parietal. So once we get this concept, we can get through this difficult terminologies. Right. So right posterior parietal lobule maintains the head center. Excuse me, sir. Hello.
Yes,
Hello.
yes, yes.
Yeah. Should I skip this?
Yeah. So, how many slides are there?
So 10 slides.
Also
10
finish
more.
it? Yeah.
Okay, I'll finish it. Yeah. So cognitive mapping. So the right posterior parietal lobe, it is basically an egocentric. Egocentric with relation to the patient's head, around the patient. So it provides an egocentric parietal window, maintains the head-centered egocentric map of space, what he is visualizing right now. And it also provides access to long-term navigational memory when required. So when he steps out into a area which he has previously navigated and he has those memories in the medial temporal lobe, the right posterior parietal lobe also provides access to that. So it's very important for topographic orientation. Right parahippocampal gyrus stores these allocentric representations of old memories of navigation, and the hippocampus is a long-term navigation, not special, long-term navigational memory. But what is the role of the retrosplenial cortex? This allocentric survey representation, it is converted into a egocentric representation as soon as the patient steps out into that environment. And for this transformation, the retrosplenial cortex or the posterior cingulate cortex is required. And what is the role of the left lingual gyrus? It is a landmark representation. So it will only remember about the specific landmarks. It is not based on any other sensory modality. Whatever famous landmarks like the famous tower or his home, his own home, or a famous building, this memory or knowledge of this recognition of this landmarks is stored in the left lingual gyrus, and this all will help in different ways for navigating. So just topographic disorientation can be egocentric disorientation, that is with reference to self and due to a right posterior parietal lesion. The patient cannot just, like while sitting in a room, he cannot judge distances, he cannot navigate around the objects in the room, he'll bump into objects even in familiar places and extend. So we see this very commonly with the right MCA territory infarct. The patient has no other symptoms other than disorientation to the actual immediate familiar place where he's standing or sitting. So this is a egocentric disorientation. Then heading disorientation is immediate environment is normal, but heading into an external environment, there is difficulty. He cannot represent his position with the external environment. He cannot draw maps or give directions, and because he cannot convert the allocentric information into a egocentric information. Then landmark agnosia, because of left lingual gyrus, he can navigate a home, he can draw maps, but he cannot recognize specific lines. So it's like an agnosia for landmarks. He can even forget his own home, right? Because it's a landmark. However, it's not a it's a problem in the visual association area, right? Then anterograde, this is also we see very commonly anterograde disorientation in patients with Alzheimer's and semantic dementia. So anterograde disorientation is cannot learn topography of new surroundings. So up to 6 months back, the new surroundings whichever he has traveled, he cannot form the allocentric representations of that, and so whenever he goes in, he's asked to go into that environment, he gets lost. This example commonly we see with hospital. So if we ask an AD patient to describe the route in the hospital, how he came to the ward or to the OPD, he'll be disoriented about that. So how do you test this egocentric disorientation? Just ask him to name the positions, special particular position of the location of the immediate objects with respect to him. Then landmark agnosia, just give him some pictures of famous landmarks or his own home and ask him to recognize them. Then that will be lost. Heading disorientation, ask him to draw a map of familiar places which he has been previously and describe familiar like route to his home from the market. So it will be impeding heading disorientation. And integrate disorientation, just ask him to how he found the way to the, how will he walk to the ward or to the OPD. So that will be lost. Then the last part is clock drawing test. It has been used since 1960s. It is a cognitive screening test. It was included. It's simple, sensitive, and effective for multi-lobe neurologic assessment. And the sensitivity is very good, as the MMS, it's 76 to 87%, but it depends on the scoring system used. So clock drawing test assesses visuospatial processing because it involves drawing and putting up the hands and numbers. So visuospatial processes are tested, and it involves planning. When we ask the patient to draw a clock from memory, planning and monitoring is also involved. So it assesses executive function, and it also assesses the semantic memory of what a clock is and the concept of a clock. Right. So first, what are the steps in testing? Draw to command. First, ask the patient to draw a clock from his memory. Give him the instruction to draw a clock face 10 centimeter in diameter, write all the numbers on it, and then draw hands for a given time, that is 10 past 11, or in Hindi you can say 10 minute 11 baje ke baad. So apart from constructional ability, it also relies on other domains because it is from memory. So executive function planning is involved, semantics of the clock is involved, and imaging or representational memory is involved. And this is worse in left hemispheric disease. But after that, you have to give him a command to copy. So in copy command, there is a lesser reliance on semantics and executive functions. So the clock is shown, the time is also set, and the numbers are also there. He just has to copy it, and this will assess specifically the construction. This is what the clock drawing was actually devised for initially, for constructional ability, but later on they extended it. So what are the errors in clock? Small clock will be seen in Parkinsonian disorders. Large clock will be seen in a visual spatial disorder like DLBD, AD. The size criteria has been given less than 4 centimeter or more than 12.5 centimeter. Then graphical difficulties because of the motor. It's a motor problem. So if the frontal subcortical pathways, motor pathways are affected, like in vascular dementia or Huntington's, so there will be a fine in motor incoordination. So there will be a wavy clock. The numbers will not be correct. They will not be very clear, and may not be intelligible also. And the hands will also be wavy, but the representation of the time and all will be correct, and we can make out the time from this. Then stimulus bound response, as we know, it is a frontal behavior. In this, when you give the patient a command of set the time to 10 past 11, so he'll just remember the strong stimulus of 10, and he'll definitely put, this is one of my patients, he'll put the hand on the 10. So he's attracted to the strong stimulus of 10 and not put the hand at 2 instead. So this will not occur with copying. So that's why the two steps are important. First, he has to draw from memory, from command, right? The conceptual errors, you cannot make out this is a clock. He has totally lost the concept of a clock. It is not showing anything. So this is semantic defect. It will be because of a lateral temporal disease. Example, anterior Alzheimer's and semantic. So whenever we see a clock like this, we have to think of AD rather than FTD. A FTD patient will have this stimulus bound response, or this is another conceptual error. See, this is the circle I drew, and the patient was still not able to put anything or draw anything. And here again, I drew all the numbers for him. Still, he could not do anything. Then visuospatial errors will be, the patient will have errors in, we all know it is because of right parietal lobe. Errors in layout of the number. So some of the numbers will be inside, some will be outside. Then counterclockwise, he'll put the numbers counterclockwise. There will be gaps in the number, and there may be drastic hemining, like in this case. So this is worst in DLBD. So this clock drawing gives you an idea of which may is the likely dementia. It's worse in DLBD, vascular dementia, Parkinson's disease dementia, and also in posterior cortical atrophy. Then planning and monitoring. This is a frontal executive problem. So one of them is perseveration. So perseveration is writing numbers beyond 12, like 12, 13 in this figure, 12, 13, 14, 15. Then recurrence of the same number, you can say 3, 3, 6, 6. This is also perseveration, and presence of more than 2 hands, right? So there is a defect. There is also a defect in, this is perseveration, then there is also defect in planning, monitoring, and set shifting. So we'll look at the example. This is classically seen in frontotemporal dementia or vascular dementia. So this patient has a severe perseveration. He has written numbers up to 25. Then this is one of my patients up to 18. And there is an executive loss. He has drawn a very, he has started from here. There is a repetition of 11, again 11 here, and the numbers are continuing. So, and he could not plan the proper arrangement of the patient, numbers. So it is a executive dysfunction. Then this patient is also showing perseveration 7666 777. This is one of my patients, very interesting, lot of hands. This is also perseverance. This is again executive dysfunction. And closing in phenomena is tendency to draw near or on top of the target, and this is typically seen in Alzheimer's. Even with the motor luria, we can see this, or in the in the graphical luria, we can see this. So if patient has drawn a clock exactly overriding on the uh, given clock, right? So this is closing in phenomenon. So thank you. My references are a lot of figures and material is from James Joseph's book, as well as from Madhusudan sir's book, and then some of the figures and concept is from Brazis. Um, Bradley's also apraxia is mainly from Bradley, and of course, most important, Rakesh sir's classes on Thursday. So the fluff, many of these things are not given in books, but sir discusses everything. So I've taken it from the notes also, some of that.
Excellent. It was,
Thank
Vikram, it was
you.
excellent. Very comprehensive
Thank
and
you, sir.
very nicely, elucidated. You
Yes.
you, you
Thanks.
prepared this from this clock was really good, huh? This
Yes, actually, I've got a lot of clocks. My own patients, I got some
yeah,
35 clocks, but I could not put all of them. And sir's book, many of them are given, both James Jones sir and Madhusudan sir's books.
fantastic. So this is
Thank
the
you.
way you have to basically approach the. See, I mean, bedside assessment is as big as theoretical. I mean, there is a lot of things which you can do at the bedside and um, elicit the science. Excellent, Vikram.
Actually,
Uh,
we often neglect the right parietal and the praxis while taking the long cases and even in the ward OPDs. But if we get the concept, I think it's very easy once we get the concept. And the tests are very simple: line bisection, cancel. These are very simple tests.
Very simple test. Yes.
Yeah. So
I just
when
wanted
to
to ask
refer?
Vikram,
Yes.
in dressing, when you check for dressing apraxia,
Yes, sir.
is there a difference between on command and patient's automatic response? Meaning somebody has a right hemispheric lesion,
Hmm.
he can just take a shirt from the cupboard and put it on. But when you actually give him a shirt to wear
Hmm.
it, he'll fumble.
Hmm.
Is there a dissociation between a command and actually automatic response, or both are impaired?
So actually, what we see with patients, like we have seen the stroke patients and CBS, they are actually the patient's relatives give the history. He takes a lot of time, so probably there should not be much difference.
Much
But
different.
I've not read about it specifically in here.
Somewhere it was mentioned that there is
Yeah.
some
Dissociation.
automatic and a command response.
So Praxis, there is definitely a dissociation, which I forgot to mention the last point in Praxis testing, real object use. So in Praxis, definitely the patient improves because of the tactile feedback and the visual feedback. The patient will of course improve, but still it affects his day-to-day activities a lot. But dressing up, I'm not very sure, sir, because it's a visual special deficit. So
You want to take this question? There is one question.
yes,
What is the difference between Dr. Debashish is asking? Difference
yes.
between purposeful wandering versus purposeless wandering.
Purposeless wandering and purposeful wandering.
Yeah,
So purposeful wandering, probably no, I think you should access. But we see it in frontal temple dementias or in uh,
that will be more like a purposeful
purposeless wandering. Yeah.
and purposeless.
And purposeful wandering, yeah, I think purposeful wandering will relate to this disorientation, topographic disorientation. So he's trying to navigate a surrounding, but he's not able to find his way. That will be more of purposeful wandering. And purposeless wandering will be seen as BVFTDs who have this uh, whenever they get a stimulus, they just turn their direction and go. Like we had that patient who went to Gujarat on his bike. So that is purposeless wandering, right?
Purposeful.
But I've not read it anywhere specific. But I think that's the concept.
So fantastic, Vikram, and it was really a very nice presentation of all the clinical science, and you covered both dominant and non-dominant parietal. And
I skipped the Alexia and agraphia part, but it would have
yeah,
become difficult to finish. Actually.
difficult to finish. Yes,
Yeah.
yes. Chalo, so let's close it. Already 10 o'clock, so
Yes.
let's close it.
Yes. Thank you, sir.
Okay, fine. So good night to everyone.
Good
Okay,
night, sir.
bye.
Thank you, sir.